good afternoon to everyone present here with us today. This is Shriyan from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Devesh Dholakia. Sir is MBBS, MS Ortho, orthopedic and spine surgeon at Gleneagles Hospital, Jaslok Hospital, and St. Elizabeth Hospital, Mumbai. With the help of Sir and his wonderful insight, we will be taking a close look on today's topic, which is emergency management of spinal trauma. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Thank you for the kind introduction. Can we start? Everybody is audible.
Yes, sir. You can start.
Yeah, a very good afternoon, all my friends, colleagues, and respected senior doctors. I'm going to talk about the emergency management of spinal trauma. The outline of the flow of the talk is going to be something about anatomy, epidemiology of the injuries, the mechanisms, the types, how do you detect it by clinical signs and X-rays, MRIs, and how do you going to manage it in a clinical practice. The anatomy of the spine, most of the doctors will know, but for the lay persons who have joined, I just talk to you. Uh, it is made up of the following parts: the cervical, that is the neck part; the thoracic is the mid part; the lumbar is the lower back part; and then the sacrum, that's the seat where we sit; and the coccyx at the tip, that's all the tailbone also in the lay public. And the front, when you see the cervical, the spine, it is as a straight line. While if you see from the side, there's curvatures added to the spine. The cervical curvature is called the cervical lordosis. The thoracic is turned the other way around, is called thoracic kyphosis. Lumbar is called lumbar lordosis. And the sacral and the coccyx also having a kyphosis segment. There are 7 cervical vertebrae, there are 12 thoracic vertebrae, there are 5 lumbar vertebrae, there are 5 sacrum vertebrae which all fuse together, and there is the single bone called as coccyx, which are made up of multiple small bones, which also are fused. So if you see, the cervical vertebrae are smaller, the thoracic is little bigger than the cervical, and the lumbar ones are the biggest. This is the front part of the vertebral body. This is the back side of the vertebral body. And the middle part is this hollow structure, is the part which houses and protects the important structure called the spinal cord and the spinal nerves which emit from it. The cervical has a better range of motion. It has inflection, extension, rotation. Thoracic vertebrae moves only in rotation. It is more stiffer because the ribs are attached to it. The lumbar vertebrae uh, also allows flexion and extension, but hardly any rotation of the body, while the sacrum helps to transmit the weight from the body to the pelvis. And between the two vertebral body is the disc that everybody calls the slip disc. Disc is that disc, which is a cushion-like structure which gives the mobility to the spine. And this structure behind the disc is the neural foramen, from which the nerves emit from the spinal cord, leaves into the upper limb and the lower limb through this neural foramen. So there are 8 cervical nerves, there are 12 thoracic nerves, there are 5 lumbar nerves, and there are 5 sacral nerves. So all of the nerves leave their respective vertebra at each level. So the spinal cord starts from the brain and goes from till L1. This is the L1, and below that, and this area of L1 is called the cauda equina, where the spinal cord and the nerves are are at a cauda equina means a horse's tail. So that's why how it looks like a horse's tail. The multiple nerves emitting from this area, therefore it's called a cauda equina region. Okay, this is how the spinal cord is. If you take a transection, the front part has the motor part, that is and the dorsal are the sensory part, while the pain and temperature is on the lateral aspect. So that's how the anatomy of the spine is. As I said, each nerve comes out from its respective neural foramen. So below, so thoracic will have L3 will come from below L3 vertebral body. So but D12 come from D12 vertebral body. The sacrum will come from if you have a sacrum S1 will come from below the S1 vertebral body. So each nerve releases from or emits from below the respected vertebral body. So the spinal cord ends at L1. These nerves have a long way to go before it emits from the respective vertebral body. There is a three-column model and formed by Dennis. It has a middle column, anterior column, and a posterior column. The anterior column is formed by the anterior half of the vertebral body, the anterior half of the disc, and the anterior longered ligament, which is in the front. The middle column is formed by the posterior part of the vertebral body, the posterior disc, and the posterior longered ligament. And anything behind that, that is the pedicle, the facet joints, the lamina, the spinous process forms the posterior column, including the ligamentum flavum, interspinous, and the supraspinous ligaments. Why this three column concept is important? This is what we had just said. It has been shown that if the middle column is involved along with anterior or posterior column, then it is an unstable injury. That means you have to be extra careful. You may further damage the spinal cord by transport, etc. Or you may have to surgically intervene in such unstable conditions. So anytime you feel that the middle column is involved with either anterior or posterior, you have to be careful. There are about 11,000 new cases per in US. So you can expect in India it will be much more looking at our population and looking at our safety industry while while people work on high skyscrapers or climb trees, etc. Out of 34%, that is one third of them are incomplete tetraplegia. 25% is complete paraplegia. 22% is complete tetraplegia and 7% is incomplete paraplegia. I'll come to this terminology a little later. Uh, Most of these injuries occur either in the younger age group because of significant trauma or in the older age group where the spine is already degenerated and a minor trauma will compound the problem. Out of this, 50% occurs in the cervical spine region. The injuries are more common in the cervical spine region. Let's look at a mechanism of the injury. Most of the injuries are are due to motor vehicle accidents or falls from height. In our country, gunshot wounds are not very common and more occurs during the battlefield or iatrogenic. This is the part which we can avoid. It is estimated that about 3 to 25% of all spinal cord injuries occur after initial traumatic episode due to improper immobilization and transport. So we could see that about 10 to 25% of the patients can be saved from further spinal injuries. You take care during the extraction and transport to the nearest hospital after an injury. It can be a direct injury, like injury directly to the spinal cord because of firearms or spine or knives, or indirect injury, that is after injury to the spinal column, the injury to the spinal cord, that is fall from a height, where there is collapse of the vertebra, and this collapse vertebra presses on your spinal cord, causing tetraplegia or paraplegia. The common mechanism of spinal injury is hyperextension injury, that is the whiplash injury we have, hyperflexion injury when people jump in when they dive in the swimming pool and the water is very shallow, you can hit the head on the floor of the swimming pool and you can have a hyperflexion injuries. Compression injuries when people jump from a height or fall from a height, the forces are transmitted to the vertebral column and can have a compression fracture. Rotation, lateral stress uh, type of injury occurs probably in motor vehicle accidents when it rolls over. Distraction injuries to the spinal column occurs during hanging. There are two ways of having injury to your spinal cord. One is the primary injury, that is damage to the neural tissue due to direct trauma, and this is irreversible. This is a structure so delicate that once you damage your spinal cord, you cannot uh, you can not reform the function of the spinal cord. It doesn't regenerate. Unlike any other tissues which have bone, it fractures, it will heal. The spinal cord is a structure which, even after healing, the function does not come back. Therefore, all this paraplegia, tetraplegia can be permanent to the patient. The primary injury, as I said, is direct damage to the neural tissue. And second injury is because of decreased perfusion after an injury, which leads to lipid peroxidation. And this releases the free radicals, which damage the cell and leads to cell apoptosis and a permanent damage to the spinal cord. Methylprednisolone is used to prevent this secondary injury by improving the perfusion and decreases the lipid peroxidation and release of free radicals. And hopefully, the spinal function will improve by preventing secondary damage to your spinal cord. So, you can have acute phase problems like spinal shock and neurogenic shock. I'll tell you what it is a little later. Also, there can be associated injuries because very often they're high velocity injuries. So, keep in mind head injuries when you have a spinal column injury. There can be multiple vertebral fractures. That is, uh, there may be non-contiguous spinal, that is cervical plus lumbar or dorsal plus cervical. So you can have non-contiguous spinal injuries, and sometimes you, if you're unlucky, you may have injury to the vertebral artery itself when it runs along the cervical spine. So what is tetraplegia? When there's injury to the cervical spinal cord leading to impairment of function in the upper limb, the trunk, the lower limbs, and the pelvic organ. That is, upper limb and lower limbs are involved. It is called tetraplegia. Paraplegia when is injury in the thoracic and the lumbar or the sacral segments. It leads to impairment of the function of the trunk, the pelvic organs, and the lower limbs, while the upper limbs function is preserved. That is called as paraplegia. Complete injury when there's the injury with no spared motor or sensory function below the affected level. There is no movement or there is no sensation below the level of the injury. That is called as complete injury and is classified as ASHI. I'll tell you what is ASHI and all as we move along. When you when you're saying it's a complete injury, just be sure that the patient is out of spinal shock. We'll come to that also a little later. What is the spinal shock? Before we label the patient as a complete or incomplete injury. Incomplete injury, where there is some preserved motor or sensory function below the injured level. The types of incomplete spinal cord injuries and anterior cord syndrome, the central cord syndrome, the posterior cord syndrome, cord equina syndrome, and Brown Sequard syndrome. These are a few types of incomplete injuries. Asia classification, that's the American Spine Injury Association. There's a classification given by them. So how do you classify them? To determine whether the patient is in spinal shock or is out of spinal shock by checking for bulbocavernous reflex. Determine the neurological level of injury. The lowest segment with the intact sensation and grade 3 or more power of function is the level of the injury. Determine whether the injury is complete or incomplete. Complete injury is called as Asia A, and incomplete is detected by voluntary by sacral sparing. I'll come to that a little later. Or there may be some visible contraction, or there may be some perianal sensation present. That means it's an incomplete injury, and there is a hope for further recovery in such patients. So that's why the importance of finding out whether the patient is complete or an incomplete injury. If it's complete, injury is unlikely to improve with time, while if it's incomplete, we are hopeful that patient will recover to a certain extent or sometimes fully after a spinal injury. And according to that, we put an Asia grade score. So where E is normal and while A is complete, there's no sensory or motor. Grade B, C, D are incomplete injuries, where D is more than 50% is of the muscles have grade 3 power. Asia C score is less than 50% has less than grade 3 power, and B is no motor and only sensory. So that's how the Asia scoring system works. And this is how a chart is there in most of our trauma. So it helps us to find out the sensory and the motor levels and give an Asia score to such patients. How do you diagnose these spinal injuries? The key points to remember is anytime you have a blunt injury to the head or there's loss of consciousness, do not always rule out a cervical spinal injury. Every patient involved in a fall from a height or a vehicle accident, things in terms of thoracolumbar injuries. Consider presence of vertebral column injury in all patients with polytrauma. Lesser injuries or minor injuries, but if it is there with neck pain or back pain or some neurological symptoms in the limbs, think in terms of a vertebral column injury. Signs and symptoms of spinal trauma are respiratory distress, tenderness along the spinal column, pain in the spinal column with movement, there's numbness or weakness or tingling in the arms or legs, loss of sensation of power in the upper or lower extremities, or there is blood above involvement. There is, in all these cases, there may be injury to the spinal column and has to be ruled out by further investigations. So you document the level of the injury, rule out associated injuries, uh, along with the spinal injuries like renal injuries, chest or sternal injuries, or retroperitoneal injuries. The injury occurs in cluster. Common areas of injury are at the craniocervical junction, that is OC1, C2, or at C70 when that is the cervicothoracic junction, or thoracolumbar junctions, that is T11 to L2. These are the junctional zones between the kyphosis and lordosis. Therefore, these are the areas of common areas of injury. Most common occurs in the cervical, but other areas are also common. Do not forget there may be tendon injuries or non-associated injuries. So always look for the whole spine or investigate by X-ray or MRI the whole spine. Whenever you have one spinal injury, do not miss the other spinal injury if it is present. Find out the level of the spinal injury. The neurological level at the lowest segment with normal motor and sensory function is is detected as side there. That is the level of the injury. Neurological assessment by sensory, motor, reflexes, and very important is rectal examination, especially in cases of spinal trauma. So sensory is 0 with no sensation, 2 is normal, and 1 is impaired. That made by dermatomal patterns. Dermatome is the area supplied by a single spinal nerve. So you have to remember this dermatome pattern so as to roughly guide us and with the level of the spinal injury. This area is very common. Important to remember is S234 around the perianal region. That's where sometimes a sacral sparing occurs, which come to that a little later. Neurological assessment, grade 5 is normal power, 0 is total paralysis, grade 4 power is with minimal resistance, grade 3 is only against gravity, yeah. Grade 2 is with gravity eliminated, and grade 1 is visible contraction. So you have to check for the myotomes. Myotomes are uh, um, group of nerves which supply us muscle group uh, with a major component like C5. When you looking for C5, the deltoid function or the biceps function is assessed. While you are looking for elbow extensions, it is a C7 root involvement. While hip flexors are L2, knee extensors are L3, 4, 5, with ankle plantar flexions S1. So each have their way to examine, and we'll have to do a motor examination which is complete for the upper and the lower limb and give a scoring system for that. So you have to examine the sensory and the motor function according to the level. Bulbocavernous reflex is a spine-mediated reflex. It is S234. So what you do is you squeeze the glans penis or put a Foley's and stretch the Foley's or tuck the Foley's, and you feel a contraction of your finger which is in the anal region. And if you can feel this, that means the patient bulbocavernous reflex is positive and the patient is out of spinal shock. It's a localized reflex. So if it is present, the patient is out of spinal reflex. It is the patient is out of spinal shock, and this is the time to look for either it's a complete injury or an incomplete injury. Is one of the first reflexes to return after the completion of spinal shock. If there's no motor or sensory function after this reflex has returned, it indicates a complete spinal cord injury. So as I was talking in the beginning, sacral sparing, that is look for sensation at S234, that is around the perineal region. Look for contraction of the the anorectal muscles. Putting a finger telling to contract. The sacral sparing triad consists of perineal sensations, a rectal toe, and grid toe flexion. That is S1. So if there is sacral sparing, it is called incomplete. Uh, it is called an incomplete spinal cord injury. But if there is no sacral sparing, there is no motor or sensory, and no sacral sparing, that indicates a complete spinal cord injury and is unlikely to recover even after your surgery, which you have planned. So complete injuries have flaccid paralysis with total loss of sensory and motor function, and incomplete will be a mixed loss depending on type of the spinal cord injury. We'll come to that. So that's complete and incomplete. Incomplete anterior cord syndrome, where the motor functions and this pain and temperature is lost because of the damage to the anterior part of the spinal cord. The central cord syndrome, where the central cord is damaged, where the upper limbs are more involved as compared to the lower extremities. Brown sequard, where half of the spinal cord is damaged, so you lose motor power on the same side and pain and temperature of the opposite side. That is called as Brown sequard syndrome, only when half of the spinal cord is damaged. Neurogenic shock, it is very common in lesions above D6 level. It can occur from few minutes to hours after the injury. Most of the time, what you will see is hypotension, bradycardia, and hypothermia. This is because of peripheral vasodilatation. Okay. So usually where you will have with hypotension, tachycardia, but in these cases you have hypotension, bradycardia, and hypothermia, and this is called as neurogenic shock. In hemorrhagic shock, you will usually have a tachycardia, but also it can happen along with this. So always keep that in mind whenever you have hypotension. Spinal shock is a spinal shock occurs because of concussion to the spinal cord after an injury. They will have loss of anal tone, reflexes, autonomic control within 24 to 72 hours, and the spinal shock may last from a few days to a few weeks sometimes. Okay, the way there's flaccid paralysis of the bladder and bowel also. And the only way to find out whether the patient is out of spinal shock is to look for bulbocavernous reflex, which I showed you before. So you confirm all your the diagnosis by adequate radiology. Take an X-ray. If you are suspecting, when shifting to the radiology department with a collar or a brace, so that there is no movement to the spine causing secondary injury to the spinal cord. So do a X-ray imaging in the depending on where you're suspecting, cervical, dorsal, lumbar region. Eh, After, if you're still suspecting a major injury on the X-ray or there is still doubt, you can go for CT scan and MRI. CT scan is good to look for structural damage to the individual vertebra or displacement of the bone fragments into the spinal canal. While MRI is good to see for the disc, the ligaments, and the condition of the neural structures. Ideally, CT scan and MRI both are indicated in patients who are undergoing surgery. The types of fractures are usually a wedge compression fracture, a chance fracture, that is through and through fractures like this from the front to the back, a slice fracture because of a flexion rotation type of injury, shear or translational injury, or a burst injury. I'll just show you why these types of injury are important. Because whenever you have injury, you have to classify it, and the classification helps us to find out what type of treatment is to be given to this patient. So we had an AO classification where divided into type A, type B, type C. So A1 were all compression injuries, and there were subtypes from A0 to A4. Type B was distraction type of injuries. There were B1 to B3, and type C are translational injuries. Along with that, you will look for your neurology and your modifiers. So according to that, you will have something like this. There's a T9 fracture, A3 type of injury with an N3, which is incomplete spinal cord injury, and M2 is the modifier here. So that's how it was. But looking at the difficulty in remembering so many things, they came up with a simpler classification called as TICS classification. TLICS, TICS classification. Only three things have to be looked for: the type of the injury, that is morphology, that is compression, burst, translation, or distraction. Integrity of the posterolateral ligament, whether it's intact, suspected injury, or it's completely injured, which can be detected on MRI, or neurological status, whether it's intact, nerve root injury, complete cord injury, incomplete, and cord icon. Accordingly, these numbers are given. Okay. And you total up all these numbers and you will have a score. If you're 0 to 3, this can be treated by non-surgical method. More than 4 will require a surgical intervention. 4 is leave it to the surgeon's discretion. He may or may not require surgery. So this was a simpler classification, and it is much more easily followed as compared to the AO classification. There was similar classification for the cervical spine also. There's AO classification. So once you have classified them and you know how to treat them, whether it's conservative or operative. So most important part for the lay person or for any person is to the initial temporary immobilization. As said in the beginning, uh, an incomplete injury can become complete while you're transporting the patient from the site of the injury to the hospital. So it's very important when you lift up the patient, it has to be as a single piece, put him on a hard board, not the canvas sagging type of uh, uh, sagging type of board or a stretcher, not a cloth type of stretcher, but a hard board. So it uh, immobilizes the spine. The cervical spine is put in a collar if possible, or puts two sandbags next to his head so as to prevent the rotation of the head. And if you have to shift him as a single piece, as a log roll, or when you want to turn him as a log roll also, like a single piece with the help of your colleagues, so as to prevent further damage to your spinal cord. This is the way to put him on the board and transfer him to the nearest hospital for further assessment. This is very important because very often you may be on a road or you may see a patient on the road, and this is how you have to, when you're suspecting some form of cervical or lumbar spine injury, it has to be handled properly and shift him to the hospital properly so as to prevent secondary spinal cord injuries. So emergency care, whiplash injury we all know is a sudden hyperextension inflection type of injuries. They usually have neck pain for the first 24 hours along with pain radiating to his shoulders or to his hands. And very often it may take up to 2 years for the patient to become normal. So how do you go about it? Once he's received in the emergency treatment, you follow the ATLS ABCDE: A for airway, B for breathing, uh, C for hemorrhage control, D for disability, and E for exposure to environment like tick area, etc. Disability. Keep the patient warm because they go into hypothermia. If the BP is less than 80 and heart rate less than 50, it has to be treated along with fluids and monitored. Gardner well tongs, if you're suspecting cervical spine injury, this is the Gardner well tongs to give traction and align the fracture and keep it immobilized. And you may start on methylprednisolone. According to the NACIS study, methylprednisolone bolus is 30 milligram per kg, followed by infusion of 5.4 milligram per kg per hour. So if the patient comes within the first 3 hours, the infusion will last for 24 hours. From 3 to 8 hours, the infusion will last for 48 hours. If the patient is received for after 8 hours, there is no chance, there is no indication of giving high dose steroids. The patient is immobilized by a rigid or a Philadelphia collar or posterior brace, or this is called the uh, halo brace, and these are the tongs depending on what you have and what type of injuries the patient has. The patient is immobilized. It can be part of a permanent non-operative management of the patient with spinal cord injuries, or it can be temporary before it being taken up for surgery. The principles of definite treatment is to preserve neurological function, to minimize the perceived threat of neurological compression, to stabilize the spine, and to rehabilitate the patient at the earliest. Treat as unstable till proven otherwise. Stable injuries, vertebral components will not be displaced by normal movements, while unstable injuries, there is a risk of displacement and further damage to the neural tissue. So, non-surgical treatment, as we already talked. The unstable injuries management principles remain the same. Needs to decompress the neural elements, stabilize the neural elements, fuse the spine, and the patient can be mobilized as early as possible. The indications of surgery are the presence of incomplete neurological injury with persistent neural compression at the site of the injury is an indication for surgery. The compression may be because of the bone fragments, disc fragments, a large hematoma, or a misalignment of the vertebra. The goal, as I said before, was to restore the normal spinal canal without additional injury to the neural elements. So let's take a few case examples. 25-year male, back pain after falling from a height. Uh, he had persistent back pain, no radiation or bladder bed dysfunction, taken treatment by the local doctor for temporary relief. When I examined him, there was ecchymosis of the lumbar spine. The L4 was tender but nil neuro. When we did his X-ray, a CT scan, and an MRI, which showed a compression fractured L4 with encroachment of the neural canal, but luckily he had no neurological deficit. The options were either bed rest for 6 to 8 weeks in a brace, and but very difficult for him because he had a job to take care of, and nobody's going to give him leave for 3 months. So what we opted was a percute screw fixation. So it stabilized internally for faster recovery, less blood loss, and patient could be mobilized at the earliest. So small mini holes, put the screws, and patient can be mobilized within a week's time and can join office at the earliest with a brace. Yeah, sorry. And another case, 22-year pilot had a high velocity injury. He had a K4, B2, N4 type of injury, that is incomplete spinal cord injury. And you can see that there is compression of the vertebral body at D12, and there is a fragment pressing on the spinal cord, giving rise to the deficit. That's the spinal cord compressed. So we fixed him up. Posteriorly, we went, punch back the fragment, feed the spinal cord of all the and compressing structures, and stabilize with a pedicle screw. And the patient could be mobilized early, and the patient recovered over the next 6 months. The other type of another injury, you can see that D12 compression fracture there in the older age group, and it was because you can see the kyphosis there and pressing on the spinal cord here. We excise the bony fragment, replace it with bone graft and a cage, and put screws so that patient had a neurological recovery and patient could be mobilized at the earliest. Another case similar, D12 compression fracture, more than 50% collapse with a focal kyphosis. And because of the compression and the local kyphosis, we decided to operate the patient, and we excised the fragment, put her in a cage, and put screws, and patient had recovery of the neurology. This is a shear type of injury which you can see when a young boy had a fall from a height. Sorry, 46-year male patient had a fall from a height. It's shear damage to the spinal column. It is a complete type of type Asia type A type of injury. There is complete sensory and motor loss. And, we realign the fracture, but there's no recovery distally, being a complete type of quad injury. But patient could be rehab at the earliest so as to have less chance of bed sores, chest problems, etc. Thank you. I'll take questions now.
Thank you so much, sir, for your wonderful presentation. So, sir, we do have some question if you'd like to take that up.
Yeah, yeah, I'll take that.
So, sir, the first question from our audience is: what are the immediate properties in assessing a patient with suspected spinal trauma in an emergency setting?
Sorry, come again, madam. What is the question?
Sure. So, sir, the question was:
Can you repeat
what
it,
are
madam?
yes,
Yes.
it was what are the immediate priorities in assessing a patient with suspected spinal trauma in an emergency setting?
So whenever the spinal injury is there, very often in the younger age group, because of their high velocity injuries, look for other injuries first. There may be brain concussion, there may be a trauma, there may be an open wound. So always go by ATLS, do airway breathing, circulation has to be kept. Spine, immobilize the spine if you are suspecting a spinal injury on a board, or the head has to be in a cervical collar, or put two sandbags on either side of the head so that there's no movement. Stabilize the patient by airway breathing and circulation. Then only you shift him to investigate by CT, MRI if required. So first is to save the life of the patient, and then you look for other injuries and accordingly treat it.
Thank you, sir. The next question is: what are the key indicators to determine the severity of spinal trauma, and how do you prioritize the intervention?
Okay. So first you have to look for, as I said, it may be very often there are multiple spinal injuries or they may be a part of a polytrauma. Okay. So first you stabilize the patient, part one. After that, once he's stabilized, you assess them clinically. If the patient is conscious, you'll be able to indicate whether the tenderness is there on the spine or not. Neurology, you can look for sensory and motor dysfunction. If there is no movement or there's minimal movement, or you are suspecting strongly there is a fracture, you may shift him for X-ray or CT scan and MRI to find out whether what type of injury is there and whether there is any compression of the spinal cord, how much is the damage to the spinal cord, and are we going to intervene after the investigations. So once you have done all in clinical, you assess them, then you do a radiology for the patient, have a scoring system, and according to that scoring system, you will determine whether to operate or not. If it's not operative, then you may require a brace or bed rest for for a period of time. Or if it requires surgery, stabilize the patient, and when he's fit for surgery, you may take him up for surgery. The aim of the surgery is to decompress the spine, stabilize the spine, and achieve fusion of the spine. And the aim is to recovery of the spinal cord, how much you can by decompressing and patient being mobilized at the earliest so as to have less chances of bed sore, chest complications, etc.
Thank you, sir. There's one last question. What are the advancement in surgical techniques or technologies that have significantly improved outcomes
Yes.
for spinal trauma patients?
Sorry, I cannot hear you, madam.
Sure, sir. Let me just repeat it for you again. What are the advances in
Yeah,
surgical
please.
techniques and technologies that have significantly improved outcomes for spinal trauma patients?
There are two things to it. One is injury to the spinal cord. So the injury to the spinal cord, if it is complete, there is no technology which can recover a complete injury. If there's incomplete injury, yes, if the patient brought early, the use of methylprednisolone has shown an improvement in the recovery pattern, or early surgical intervention by decompressing the spinal cord of the encroaching structures has shown an improvement of the patient. That is part one. So there is no newer avenues at present to help in recovery of a complete spinal cord injury. Tech Technology in fixation wise, yes, we are able to fix them with percute screws, as I had shown in one case, so that there are less cuts and patient can be mobilized at the earliest. So there is new technology with percute screws. There's less smaller incisions, less cut, less bleeding, less chance of infection, and less pain, and faster rehab of the patients can be done with the use of microscope, birds, a lot of technology is available to cut a bone faster and aggressively and with safety. So a lot of technology is there to for the surgical intervention, but there's no technology at present for recovery of the spinal cord.
Thank you so much, sir, for answering all our question. That's all from our audience, sir. So, sir, before concluding, any take-home message from your end?
Yeah, take home message, I would like to say that very often we see that the way they are handled by the people on the road or even after an accident or after a building collapse, you can see them putting them or pulling them out from the debris, or then they're shifting on a canvas, stretcher. This can further impair the spinal cord injured patients. So we have to be very careful if you have a spinal cord patient, put them on hardboard, put bricks on either side of the head, wait, put them on the floor and then shift them once the hospital is there. Don't twist and turn him. So that would be the most important message because, as I said, 15 to 25% patients of incomplete becomes complete because of the way we shift the patient or way we transport the patient from one place to the other. So that is the thing which we can avoid. As I said, a complete injury does not improve even after a surgical intervention. There's no technology as yet. So it's a very bad situation for everybody if the patient has a complete injury. So I would say that if always educate people on how to excrete, or I would say how to remove the patients of injury from the site of the injury, that is the road or the building collapse, to the hospital. I think that's how we should be taught.
Thank you so much, sir, for joining us today, sir. And it's been a pleasure, sir. And thank you again for joining
Thank
us.
you.
And with your permission, I would like to conclude today's session, sir.
Thank you very much. Thank you for giving me an opportunity. Thank you.
Thank you, sir.